Are we good or not? Are we hooked up to the wall?
Yes, we are.
That's too bad.
Here it is.
Morning, everybody. Everybody seen the slides? All the right answers? Are we ready to go? Is that a yes?
Yes.
Okay. So I will ask for a volunteer from one of the first years to take this on. Thought I'd start with a relatively straightforward case, and if nobody volunteers, I'll volunteer you. Good. Just read the history. You don't have to get up. You just do it right off there, unless you don't want to.
Case 1.
Case 1.
21-year-old male with a radiolucent vaginal mass.
Okay. What do you see?
So, the surface epithelium is squamous surface epithelium with.
Stop. You got to be careful, right? Whatever you say matters. Are you sure there's surface epithelium?
Not 100% at this point.
Okay. At what time will you be sure? At 8:05? So you got to be careful. What's the surface epithelium of the mandible? There's no surface epithelium. Where's there a surface epithelium? If we're talking about this location. It's just simple. You know, it's what would be the surface epithelium?
Not characterized surface.
Well, from what body part? It's mandible.
No.
So it'd be from the oral cavity. I mean, we're just keeping it simple. So you want to take back what you said about surface epithelium?
Yes.
Okay. There is no surface epithelium here. So what is there? If I was just going to say to you, is this neoplastic or non-neoplastic? And forget about the type of neoplasm. What would your answer be?
I would say it's neoplastic.
Neoplastic. Okay. So even before you put the slide down, 21-year-old, doesn't make a difference gender, radiolucent mass. So in your mindset, when you're starting to put together, you know, a differential or an algorithm to try to make a diagnosis, you should be thinking, what? In this location, with a mass lesion. You already said one generic concept, neoplastic. What if I said to you that this is, forget about what's on the slide, non-neoplastic. So what would your options be at that point? Non-neoplastic mandibular mass, just for lack of a better description. What benign lesion? That's what I'm trying to get at. What group of benign lesions? We're dealing with what component? It's not the oral squamous mucosa. No answers. One person. Seriously, this is an educational. We don't need everybody telling each other things. So, what group of lesions? That we as surgical pathologists don't usually see. It's really more in the oral pathology world. Odontogenic. Odontogenic what? If it's not neoplastic, it's cysts. Okay. So I just, just frame of mind when you're looking at cases. You're going to get out of here after 4 years, maybe do a fellowship, go into practice. This is something, odontogenic lesions, you're not going to see, but one might come up. So you just have to keep it more general. Okay. So you take it from here.
Okay. Well, I see some, I guess, some islands of, I would say, like, I don't know what type of cells, but blue cells in the stroma.
Okay.
Underneath.
So in the scheme of neoplastic, the way this is growing, do you think this is an epithelial neoplasm, a mesenchymal neoplasm, a combination, something else?
Maybe epithelial.
Okay. And generally speaking, when things grow in cohesive units like this, it often means, but not always, you're dealing with an epithelial. Forget about odontogenic, just in general. Okay. Okay. Now we're at a little bit higher magnification. How would you describe this?
Well, I see some cells encapsulating, I guess, there's like basal cells.
Okay, let's stop because you're using the word encapsulated. What pattern of growth do you see there? When you say encapsulated, doesn't preclude invasion, but you usually mean something that's clearly defined. Does this look to you like it's clearly defined in terms? No. So the individual nests may have some envelopment, but they're not encapsulated.
So surrounding, I would say.
Is it warm in here or is it my imagination? It's warm. Cool. Is there any way to change the, turn on the air conditioning? Or lower the? Okay. So here, let's stop here.
So I would say cells surrounding an A, yes. Linear order.
So they're pretty sharply demarcated from that kind of myxoid, mucinous appearing stroma. And there's some eosinophilic material around the cluster, the cell nests. Okay? What about cell type?
I believe it may be squamous.
Well, before we get to that, just describe the cell types.
So there are some that are like columnar looking.
Good. And where are they in the scheme of the nests?
Surrounding the nests.
On the periphery. On the periphery, right. Okay.
And then there are some that are, I would say, some like spindle.
Okay, but looser appearing.
Loose. And then some music, some that may be cuboidal, just transitioning very haphazard within the nest.
Okay.
And then in between the nests, you have that myxoid background.
Yeah, that's kind of a secondary player in this. We're not too concerned about that. So what can you tell me about the orientation of the nuclei? And this may be not the best example, but here you don't see what I'm pointing to here.
It's like polarizing. So
Yeah.
it's opposite.
Yeah, so it's another word for opposite. Reverse polarity. Okay. That's characteristic of this. This morphology is a dead ringer diagnostically, especially in this location. So do you have a diagnosis?
I think it's Ameloblastoma.
Ameloblastoma. Everybody agree? What if I told you this was a 65-year-old man who's got a purely intranasal lesion with this histology? X-rays, no relationship to the jaw, to the maxilla, entirely within the sinonasal tract. Would that change your diagnosis? This is open for anybody. Same identical histology, but now you're in the sinonasal tract. You're not in a gnathic. Gnathic means jawbone, maxilla or mandible. So it's not a gnathic lesion, but it's sinonasal tract. in a 65-year-old man, 53-year-old man, 75-year-old man. The man part is important, but we'll get back to that. So it's purely within the sinonasal tract. Are you changing your diagnosis? Anybody?
No.
What are you going to call it?
Adenocarcinoma.
Why? So in this jaw, you're calling this ameloblastoma, but in the sinonasal tract, you're calling it ademantinoma.
Divided in the bone.
Same diagnosis or different diagnosis?
Same diagnosis. Extra what?
Dr. Modica.
Extra, special word, extra.
Yeah, there's only one extra special word, sinonasal ameloblastoma. They do occur there, middle-aged, older men, identical histology. And this is classic histology. In that middle material, it's called stellate reticulum because this neoplasm recapitulates the donogenic enamel organ. So if you look at fetal, you see this is normal. So this is the growth pattern, but it occurs in the sinonasal tract, but you have to exclude connection to the jaw. Okay, so we'll come back to this. Is this benign or malignant?
Benign.
Okay, how do surgeon calls you up? It's unlikely, but says, what do you, ameloblast, how do I treat that? What's the treatment? It's not enough just to make the diagnosis. You're going to be asked, and those of you who have come to this conference before, I harp on the fact that it's not enough just to know the diagnosis. We as pathologists will be called upon, some more, some less, to provide additional information, which you may need to read about, which is fine. But, we're the answer people sometimes on everything. Not always. Surgeons, know how to deal with this. So what's the therapy for this?
It's a benign lesion. It's indolent.
Huh?
I'm not sure. I would say
Okay, that's a good answer. Not sure. What's the treatment?
surgical incision.
Surgical excision. Do these recur?
Yes.
Yeah, they sure do. When they recur, we now call them malignant?
No.
No. When do you call these malignant? Under what conditions can you call an ameloblastoma a malignancy?
When there's metastasis.
Then what are you going to call it? Same histology or different histology on the metastasis?
Same histology.
So what do you call it then?
Malignant ameloblastoma.
Okay, and what's ameloblastic carcinoma? Is it same, different?
Different, I would say.
Okay, how different?
It would be more atypical.
It will be outright malignant, morphologically. Okay, good. So these can metastasize in the same histology, it's called the malignant ameloblastoma. But when you have cytomorphologic evidence of malignancy, carcinoma, we call it ameloblastic carcinoma. Are there any other malignancies that we can see that speaks to other variant benignancies that confer a different diagnosis on the malignant side? Anybody? Think stromal component. You can have benign fibrous proliferation, ameloblastic fibroma. So therefore, if you have benign, you can have malignant ameloblastic what? Fibrosarcoma, treated like a sarcoma. So this is this histology, just keep it in mind. The problem is that little biopsies of an oral cavity lesion where you don't have information, the basaloid morphology nature of this, and there are variants. You can get ameloblastic acanthomatous or outright squamous differentiation. There can be some confusion with other neoplasms like adenoid cystic carcinoma. Less likely basaloid squamous carcinoma because that's a high-grade malignancy. Okay, good job. Any questions? Okay. Number 2. Okay, Mallory, I'm volunteering you. Just read the history.
Case number 2. We have a 75-year-old female with ventral tongue top.
Okay. What are you seeing?
So
Forget about the black dot for now.
So I see what appears to be squamous epithelium
Okay.
with underlying subcutaneous tissue.
Well, it's oral cavity, so it's not by definition subcutaneous, submucosal.
Submucosal tissue. And at the surface, I see what, or at the subdermal area, I see a
Subepithelial.
subepithelial, a band-like infiltrate.
And that emits magnification, looks like,
So it's lymphocytic.
well,
Or-
inflammatory cells. So what's a general term, just based on this, that you can use irrespective of what the end diagnosis is? Got a band-like inflammatory infiltrate hugging the squamous epithelium, and even probably going proliferations within the oral cavity. Do you know?
No.
Anybody? Lichenoid, what? Lichenoid what? It is lichenoid. What's the next word?
Inflammation.
Okay, but of what? Of the mucosa. Lichenoid mucositis. Right, it's not skin, it's mucosa. So lichenoid mucositis. Anything else going on here? So now we're getting to a little bit higher magnification. Is there anything, and generally speaking, when you get an oral cavity lesion, leukoplakic, erythroplakic, however they're describing it, and this entity can have different appearances, white, red, can be ulcerated. We're looking for dysplasia. You know, oftentimes, you know, our eyeballs don't focus on the inflammatory component, but we're looking at the epithelium. So if this is the general view of the entire epithelium, is it dysplastic? No. Anybody argue with that? So it's not a dysplasia that we're worried about. So the history is important. It's an older woman, right? They're more prone to these kind of lichenoid mucosities. So what would you say about the inflammatory infiltrate, both in its population and where it is?
So in this tower, it appears to be, as we said, also invading into the epithelium.
Okay, you can use invading, permeating, extending. It's blurring to some degree that interface.
Right.
Okay? Does that make it diagnostic? No. And these kind of lichenoid mucosities really requires a lot of clinical correlation. It's not necessarily one diagnosis all the time, but you know, that's a generic term that could apply to an idiopathic lesion, a hypersensitivity to drug, some topical stimulus that might cause this. And oftentimes we as the pathologists can only give a descriptive diagnosis there, probably. So having said that, what do you think the differential is here? And the dot is pointing to some of these, what appear to be dead keratinocytes. See it in the field. Doesn't project great, but right here. So what do you think the differential is? And a lot of times we're just faced with a descriptive diagnosis and giving a differential diagnosis. But among the differential diagnosis, an older woman with a plaque-like lesion, papule on a ventral tongue.
So you could think it broadly, as in possibly a common.
Okay. Any specific diagnosis within that autoimmune category?
Lupus. And sometimes it's
Yeah.
very,
Pretty unusual to get oral cavity involvement, but common things occur commonly.
think like inflamus.
Right. I think that's the first thing you should think about. And you can say, depending on what the clinical scenario is, these findings may correlate to a diagnosis of lichen planus. okay, which can be idiopathic. And then you can have, like I said before, secondary involvement due to drug reaction, just not unlike skin lesions. And also some friction or other issues. Can you get dysplasia associated with lichen planus? So this is lichen planus. Turns out this woman has lichen planus. What about dysplasia in cancer involved with lichen planus? Common, uncommon? Anybody?
Uncommon.
Huh?
Uncommon.
Uncommon. More than 5%? Less than 5%?
Less than 5%.
Less than, good guess. Less than 5%. But, you know, there's a lot of maybe misinformation in the literature where, you know, lesions presumptively are lichen planus with dysplasia and invasive cancer, when in fact they were never lichen planus, but dysplasia and invasive cancer with secondary inflammatory reaction. But these are challenging. They're not that common, at least in the general practice. You know, some people who are oral pathologists, by virtue of either their practice or where they're located, have a larger volume of these. But in all probability, day to day, you know, before we merged with Mount Sinai, I would say these were pretty uncommon. Now, by the nature of their clientele, they tend to be a little bit more common. Okay, good. Any questions?
I have a question real fast.
Sure.
If you have a cutaneous lichen planus, you can also see the liquid striae in the mouth.
You can, yeah.
What would it look like lichen planus, oral lichen planus?
Would what look like?
Histologically, or would it?
These cutaneous ones?
No, the liquid striae that you see in the oral mucosa.
Yeah.
associated with lichen planus. Does it look similar to oral lichen planus?
Yeah.
Histology?
Yes. Okay. Number 3. This is among the more common things that we'll deal with. So this is a 59-year-old with leukoplakia. Just remember, these terms leukoplakia, erythroplakia are clinical designators. They're not something that we use in pathology terms. Okay. Motion.
Yes. So on the lower part we can see squamous mucosa, which is ferociously growing.
Which is what?
It looks warty.
Ah, okay. Okay, looks warty.
Thickened epithelium.
All right.
And
I should say this is the initial presentation. This is not a recurrent persistent lesion. So the reason I give this to you, maybe this is not the greatest example, but it's just a way to deal with these squamous proliferative lesions and what the issues are clinically and for us diagnostically. So description is good. Do you think this is an adequate biopsy?
it is.
Because,
I see a lot of tissue and I see the pathology right up there.
okay, what if I gave you a lot of tissue that was purely epithelium? Would that be a sufficient biopsy? And you see a lot of pathology too, to use your definition of adequacy.
Now I would love to see some semicolon.
Exactly. So that's the critical point. I mean, these are exophytic lesions, and they can be quite exophytic, and the surgeon biopsies a lot of tissue with a lot of pathology, but no submucosa.
We do see the submucosa and it's warty growth, and the squamous epithelium seems very thickened, and there's dead keratin on top.
Okay.
This is all I can say on low power.
What about the way that it's growing and whether there is or is not dysplasia? So what's the pattern of growth in terms of the reedy ridges?
The reedy ridges, they are not invasive, they are lengthened and intrusive.
Well, okay. What I use is elongated and extending in a downward fashion. But essentially the same as what you said. But does not have an infiltrative pattern. So they're clearly here, and here's a good example: elongated, rounded, and growing, extending downward.
Right.
Okay, so what about cytologically, if this is an example of everything? So dysplastic or non-dysplastic?
They are non-dysplastic.
So why don't you share with us your criteria for dysplasia,
So
cytomorphologically?
So for dysplasia, I will be looking for variable size nuclei, and the nuclei will be irregular. The nuclear membranes will be different, and they can be hyperchromatic.
What about NC ratio?
NC ratio is usually increased.
That means the nuclei are enlarged.
Yes.
So nuclear enlargement, nuclear pleomorphism, increased NC ratio, irregular membranes, hyperchromasia, anything else. Look how uniform the cells are. They're all respecting pretty much one to another. So when they lack that respect, there's an absence of polarity. Right? What about mitoses?
Yes. So we can see mitoses in the basal layer, but if we
Good.
see more mitoses up there, and
Good.
especially abnormal looking, then that is definitely one of the signs of dysplasia.
Okay, so for upper airway, since I introduced the concept of dysplasia and it was nicely described, the most common type of dysplasia in the upper airway is one that has keratin. If you know, and by now you've all seen uterine cervical dysplasia, generally it's non-keratinizing. And you get a gradation of mild, moderate, and severe from the basement membrane up to the middle zone, which is moderate dysplasia, and full thickness, either severe dysplasia or carcinoma in situ. So you do get non-keratinizing dysplasia of the upper airway, but it usually occurs in locations that patients don't present clinically early in the disease course. Supraglottic larynx, subglottic larynx, nasopharynx, areas that are clinically quiescent until the tumor invades. The same is not true in the oral cavity and the glottic larynx. Those are usually keratinizing dysplasias. And you can get, and I don't think I gave you an example, of dysplasia entirely limited to the lower zone. 2/3 is benign, just like this, and it invades. So having said that, is there a role for P16 and Ki67 in the diagnosis of upper airway keratinizing dysplasia? Yes or no? How many yes? Raise your hand. Okay, how many no? Nobody. Okay, so if you have dysplasia entirely limited to the lower zone, how does Ki67 help you? We're looking for extension up. 2/3 is benign. It's going to be Ki67 negative. So how does that help you? The keratinizing dysplasias, are they HPV associated or not HPV associated? So how does P16 help you? So those of you who raised your hands, the next time I ask that question, don't raise your hand. And none of you who raised your hand for no or it's not helpful, you need to raise your hands next time. Are there exceptions? What are the exceptions, if any? Silence is not golden. What about tonsillar dysplasia? Base of tongue and palatine tonsil.
Emilio, who has hair.
Does carcinoma in situ exist in that location? I'm not saying that it doesn't help, but if we're talking about intraepithelial dysplasia, so you see patient has a 3 centimeter neck mass, no mass lesion anywhere else, blind biopsies endoscopically, base of tongue biopsy, you see what looks like in situ cancer is the only nidus that you see. There's no invasion. So is that in situ, or is that the focus for the metastatic cancer? And does P16 and Ki67 help you in that instance? So I'll answer my own question. There's no such thing as carcinoma in situ in the tonsil. If you see that by virtue of the type of epithelium it is. It's a reticulated epithelium with lax interconnections. And within that epithelium, there are also lymphatics and vascular spaces. So if you see that, you don't call it carcinoma in situ, because if it's carcinoma in situ, it can't metastasize. You may answer, well, you know, they missed a biopsy, it's somewhere else, it's invasive. That might be true. But if you see something that looks like what you otherwise would call carcinoma in situ in that location, in the base of tongue and tonsil, that should be considered cancer and the focus for metastasis. You could do Ki67 and P16. And P16 will light up all the epithelium, and Ki67 will be full thickness. But it's already, by definition, invasive. There's an oral cavity, there's a couple papers published 2 years ago, of oral HPV-associated dysplasia. It's a type of dysplasia that's keratinizing, has increased karyorrhexis and dysplasia cytomorphologically, and the authors, 2 different papers, almost the same month, identified transcriptionally active virus. In that instance, P16 would help, and probably Ki67. But in general, keratinizing dysplasia of the upper airway is not HPV associated, so P16 doesn't help you, and the dysplasia can be very limited. So having gone through all of that, we come back to this case. So how are we going to deal with this? No dysplasia, clearly a hyperkeratotic, verrucoid or papillary squamous epithelial proliferation. Clinically, rule out verrucous carcinoma. Are you going to want to call that verrucous carcinoma? Why not?
I don't see any signs of carcinoma. There's no dysplasia. They're
Okay.
respecting each other.
Time out. What's the definition of verrucous carcinoma? That'll answer your view of it. Anybody? Non-dysplastic epithelium. By definition, verrucous cancers do not have any dysplasia. Again, recent article 2 years ago out of Washington University identifying dysplasia, that they accepted some form of dysplasia and even minimal invasion as part of verrucous carcinoma. But in generally, that's the epithelium you see in verrucous carcinoma. So that's a learning point. So now do you want to call it verrucous carcinoma?
It's among the differentials.
Good. Good answer. It's among the differential. And the key information I gave you is this, the initial presentation. How do you know this is not some floored reactive process? If we go back to it, I mean, it's not too proliferative to be a papilloma. Could that be reactive?
Could be, yeah.
What tumors do you know of that can induce a squamous hyperplasia like that? Anybody?
Granular.
Granular cell tumor.
Granular cell.
Okay. So there's no granular cell tumor, but to answer my question, that could be reactive. You don't know that. The patient might have something that's inducing that. We don't know. So that's the point. This engenders a differential, and one way to handle it might be verrucoid, well-differentiated squamous epithelial proliferation as your diagnosis. And in a comment, say the differential includes verrucous carcinoma. Certainly if this kind of lesion recurs 6 months, a year later, then it's more likely at an appropriate time to make a diagnosis of verrucous carcinoma. What's the other definition of verrucous carcinoma from a biologic standpoint that separates it from conventional squamous cancer? Which is why if you don't call this verrucous carcinoma and a year later it recurs, and you do, nobody can fault you.
Non-invasive.
Okay, non-invasive, but more importantly, with invasion comes what? What might occur secondary to invasion?
Metastasis.
Metastasis. These verrucous cancers don't metastasize. They may recur, but they don't metastasize. So you give a generic diagnosis, you recommend complete excision, and follow up with the patient. But these are problematic because you'll see these day in, day out if you're in a head and neck practice or a practice that's a lot of head and neck volume. Okay, any questions?
So we can call it a papilloma, squamous papilloma, it will not qualify, right?
No, it's tangential. Some of it looks papillomatous, but it's way too proliferative to be just a conventional. It's not exophytic only, it's endophytic.
So there is some candida somewhere we saw, like there.
On the surface, so that brings up another thing. If you see a lot of neutrophils, it might be just colonization, but it's worth doing stains because on a rare occasion, patients get fungal infestation where you have to find the fungus deeper in the epithelium. That can induce a hyperplasia like that. That needs topical fungal antifungal therapy, and it should go away.
So it means,
But you should report fungal colonization.
What about ulceration, Dr. Wenig?
What about ulceration?
Verruciform, is it an important feature?
No. Okay, so we did 3 cases in a half an hour. I think we need to move on. Okay. Okay. What is this? This is a 28-year-old female with a heart palate leukoplakia lesion. Okay, Zachary. You're up.
Okay.
I woke you up, huh?
I was okay. So what I see here from this magnification is I see some hyperchromatic cells.
What's the pattern of growth? Start at low magnification. Just start with what is you're confronted with is architecture more than cytomorphology. Is it? I don't want to put words in your mouth. So you tell me. So this is described as a leukoplakic lesion, but if you were looking in this person's mouth, how would this look to you? Exophytic, endophytic?
Perhaps exophytic?
And does it have finger-like projections? So more or less?
Yes, I see the finger-like projection.
And what terminology could you use for that? Not undifferentiated than the last case.
I mean, it could have a villus-like.
Okay. But villus is more terminology we use in the gut. It does start with a V, but the second letter is also a vowel, but not an I.
That's a
Verrucoid. Okay, there you go. Verrucoid. If we keep this simple, not just here, but every day, in and out, just don't complicate it. It's complicated enough. Your lives will be a lot easier. So verrucoid, okay? And hyperkeratotic.
Yes.
Anything else? Since we need to move on, we'll just go a little bit quicker. Dysplastic or non-dysplastic?
It looks non-dysplastic.
Good. Anything strike your eye here?
Perhaps some of the looks like maybe polymacrophagia.
Good. What immunostain could you use to prove that?
Use a PAS.
I said immuno. You can use a PAS. It's probably going to be PAS negative.
Okay.
Could be positive. There might be glycogen in there. But if it was PAS positive, would you expect it to be digested with diastase or retained?
Retained?
No.
No. Okay.
Because if it's retained, then it's epithelial mucin. And if you think these are macrophages,
It's not
they may be engulfing, right?
We use like a CD68 or
Yeah. And if these are macrophages, would it be CD68 positive?
I think so.
Yes.
Yes.
Yes. Try to be more definitive in our answers.
Yes.
Okay.
Positive, for sure.
What if these were Rosai-Dorfman cells? It's a little bit unfair to ask you, so you can consult
I'm going
the
to say it's probably going to be negative because we're
CD68 negative.
It's a what?
Agree? Everybody agree?
No.
CD68 positive, but what else will be positive?
S100.
That's one.
S100. And what if they were Langerhans cells, which they're not? Are they S100 positive?
Yes.
Yes. What else are they positive for? Which differentiates them from Rosai-Dorfman cells? And the other term for Rosai-Dorfman is sinus histiocytosis with massive lymphadenopathy, but in an extranodal site, you use the word extranodal. So Langerhans cells are S100, CD1A, and Langerin positive. And these cells are only CD68 positive. So this is all you get. You have to give me a diagnosis now.
I have to give the diagnosis.
Yeah.
Okay. So Verruciform is xanthoma.
Okay? Anything else?
I mean, there's a differential for it. I would have the differential.
What's your differential?
I mean, you could also be a condylarma accumulata. It's a verruciform.
A what? Oh, condyloma, okay. Not so much. Generally, you won't have this kind of pattern in these histiocytes. So, you know,
also more verruculous carcinoma.
Yeah, generally, it doesn't have the same appearance that we had in the last case. It was mostly exophytic and not growing in a downward fashion. But this is a Verruciform xanthoma. So pretty straightforward case. Morphology is pretty characteristic. So I just wanted to take you around a little bit. Okay, number 5 is a 75-year-old with a floor mouth. Okay. Dominic.
So, from this power, we see it's like I guess
There's normal, right?
Yeah.
So, is the surface where the pathology is?
No.
Okay, where's the pathology?
Meat, stroma.
Okay, and what do you see?
I see a lot of clear-looking cells intermixed with.
All right. Any particular growth pattern?
It's infiltrated.
We'll get back to that, but just in terms of the, the grouping of the cells. Cohesive, non-cohesive?
Some of them are not cohesive, and then here others are just nested.
Okay. So what do you want to do with this thing? Do you think this is neoplastic or non-neoplastic?
Neoplastic.
Okay. Just for sake of time, because I got bogged down. So what do you want to do? Do you have a diagnosis, or do you need any kind of stains?
No, I'm gonna need the stain.
Okay, so let's start with the simple things. Histochemistry, what do you want to do? 3 stains.
I guess I'll do a CK, LC.
Histochemistry, not immunohistochemistry.
Oh, I'm sorry. Oh, okay.
You want to prove whether there's something in the cytoplasm or not, because these are clear cells.
Right.
Okay?
Right.
So before we jump to the immuno, you should order histochemistry, right? That'll come back sooner than that. So what are you looking for? Presence or absence of?
Mucin.
All right, so what do you want to do? Mucicarmin is negative. What else? PAS and DPAS. And what would you expect to find in that?
Positive.
For what?
For mucin. Or yeah, if they were mucin.
No, mucicarmin is negative.
Oh, okay.
PAS is positive. And what do you think is going to happen when you digest it with diastase? It stays or goes away?
And then it would go away.
Usually goes away. Okay, let's go to the immunohistochemistry.
So I started to say CK7, but actually I don't think.
Well, you could just say cytokeratin.
Okay.
So the cytokeratins are positive.
So it's just epithelial.
Anything else you want to do?
S100.
Okay, maybe positive, maybe negative, but S100 is important for a different reason. One other stain. Anybody?
I will rule out RCC.
But we didn't get to that yet. One other stain to prove what this entity is.
Well, even epithelial stain.
Well, we have the keratins. They're positive.
Vitamin.
No, Vimen's not going to help you.
Carbonic anhydride or
We can rule out metastasis after we do another thing. I know it's not fair to P63. So I'm telling you, this is keratins positive and P63 positive, diffuse and strong. You want to rule out a MET? A renal cell patient has no history. Does that mean they can't be a MET? No, it can have an occult renal cell. So whatever you want to do, RCC, CD10, PAX8, negative. So what's the diagnosis?
I wasn't sure actually what the diagnosis was for this one.
Okay.
Maybe some sort of clear cell adenocarcinoma. If it was metastasis.
It's not a metastasis. This is a clear cell carcinoma.
Hyalinating.
It has hyalinization, so it's a hyalinizing. Associated with what translocation?
1722.
Huh?
Is it 1722?
Ewing's,
1121.
1122. So this is associated with Ewing sarcoma translocation. This is a minor salivary gland origin. And this histology, generally, renal cells have more a crisper-looking cytoplasm, and they have red cells in the center of the luminal aspects. Okay. I don't know that we're going to get done today, but we may have to finish up another time. So number 6. Number 6 is 21-year-old with a right neck mass. Any volunteers? Or am I volunteering somebody? Take a more senior person. Go ahead, Rifat.
So what we see here at this magnification is there is a cystic structure, and we do not see a lining at this part. There is a lot of vascular congestion, and these are minor salivary glands that we see in the periphery.
Okay.
So here this seems that the cyst is lined by this inflammatory granulation tissue with some myxoid stroma, and it's
Okay.
more like an inflammatory granulation tissue. And there is some thinned out lining in the periphery, and thinned out probably squamous lining somewhere, but mostly I don't see.
All right. So what do you want to do with this? Anything?
I want to process more to look for epithelial components.
Okay. Everything is processed. You're looking at it.
So it's basically, I would say that I want to know what was a clinical picture. I would just call
Neck
it
mass.
clinician. Sorry?
Neck mass.
Neck mass. I think it is still a retention cyst-like a thing, maybe mucosal.
Any stains you want to do?
A cytokeratin to see if there is
It's negative.
no specific stain. I don't have any stain in my.
A mucin stain might be helpful. But you're going in the right direction. This is part of a plunging ranula. Patient did have a floor of mouth lesion and then developed a neck mass. And so when that ranula, which is epithelial line, permeates the muscles in the neck, it extrudes mucin into the neck, and you get a granulation tissue-like reaction here. Mucin stain might be helpful, but you might just see some, very weak staining in this fibroconnective tissue. So this is a descriptive diagnosis that we need clinical information on, but it's called a plunging ranula. A ranula is a floor of mouth, epithelial line, mucus-retained cystic proliferation that could penetrate the muscles, usually in a younger person. So this is really all you see, but clinicians, are often worried about some neoplasm. Okay. Number 7. Okay. Any volunteers? Among the seniors?
So on the lower part, it looks like
Another. Oh, you get to do 2. Okay. You're saving your Everybody else, what do you think?
So the lower part, this is a tonsil mass. So this is definitely tonsillar tissue.
Right.
We see the mucosa, and we see some lymphoid aggregates underneath. And there are more interesting areas in the slide, I think.
There are? Okay. See if I can get your interest. You tell me where to stop.
Okay.
Keep going?
Yeah. Keep moving. Over there. So on the periphery, we did see some normal salivary glands. So this looks like cartilaginous tissue,
It is.
but in the tonsil.
Okay.
And
So-
there is a very particular name for this.
What is it?
It's not a hamartoma, it's a choristoma.
It's a what?
Choristoma.
Oh, choristoma. Okay.
This is what I think it is.
Okay. Everybody agree? What about this?
There is an atypical lymphoid proliferation also.
Okay.
So,
There are three things on this slide. One was just described.
yeah.
Second one was just described. But it's really polypoid. And what are all these vessels doing? Is that normal? With the lymphoid component? So this is a lymphangiomatous polyp. But we're not done. So two things. What's the third thing? You described an atypical cellular proliferation?
No, the lymphoid cells at some places they look atypical.
And so what do you want to do?
So and there is some like if lymphoid cells are invading into the epithelium at places, but some of these are probably part of reactive, but some cells look really very bad. So
Okay.
I would like to do CD20 and CD3,
Okay, they're both positive.
but that doesn't.
So here's this thing.
Yeah. So this is not. See, this is EBV, I guess.
This is Eber.
Yeah.
So what do you want to diagnose?
So
CD3 positive, CD20 positive, Eber positive.
so then it is non-neoplastic.
What is it?
NKT cell.
No, non-neoplastic.
No, an NKT cell. We're in the tonsil. I guess you can have an NKT cell there, but it wouldn't be CD20 positive. What tonsillar lesion is associated with EBV? Non-neoplastic. Can have extremely ugly looking nuclei. College students. Infectious mono. So you have a choristoma, lymphangiomatous polyp, and infectious mono. Not your run-of-the-mill case. Okay, we have a little bit of time left. So this is, let's see. 55-year-old man with a lip mass. Since we have a short amount of time left, we'll just open this up. So where's the lesion? Submucosa. Large cyst, there's some epithelial lining, and then you have, at this magnification, what kind of proliferation?
Basaloid,
Basaloid. Growth pattern?
Cribriform,
Cribriform.
microcystic.
Trabecular as well.
Huh?
Trabecular.
A little bit trabecular, maybe a little bit canalicular. So what do you want to do? Or do we have a straightforward diagnosis?
Look for invasion,
No invasion.
then benign,
Can you have non-invasive? Is this, what kind of lesion is this?
salivary gland.
Minor salivary gland. Can you have salivary gland lesions that are malignant, that are non-invasive?
Yeah.
So invasion doesn't exclude malignancy. So name me some salivary gland tumors that are malignant that don't necessarily need to invade.
Acinic cell,
One.
mucoepiderma.
And these are tumors that by their cell type are defining their diagnosis. So there's no benign tumor with those cell types. Actinic cell, there's no benign tumor that we know of. that has an actinic cell proliferation. And when you always think actinic, you need to think about mammary analog secretory carcinoma, which used to be part of the actinic cell adenocarcinoma. That's another tumor you don't need invasion, but you have to have the right morphology and immuno. What else?
Polymorphous low grade.
No, that one you probably need invasion. There's no way to separate that out definitively. Adenoid cystic,
Yes.
but you really have, is this an adenoid cystic?
No.
Why not?
There is this basement membrane material.
You can get basement membrane material.
And
in
the
adenoid.
cells are not there. There is a lot of tubular formation. And
You can have tubular formation in adenoid cystic, and it's a basaloid neoplasm.
Still has invasion.
Yeah, you don't need to have invasion, but you
the
better be sure that it's an adenoid cystic before you call it adenoid cystic with no invasion. So it's-
peritoneal invasion.
well, if you don't have invasion, if you see all the classic morphology, but it should be cribriforming and not microcystic. It should have the predominant cell type should be the abluminal and myoepithelial cells and a very minor component of true duct lining cells. And this doesn't have that morphology. So what's our differential? So this is benign. And after that, it doesn't really make a difference what you call it. In the lip, there's a common benign salivary. Is this a pleomorphic adenoma?
No.
No. Why?
It's to have three components.
Well, it doesn't have chondromyxoid stroma. It probably has epithelial and myoepithelial cells. So it's not a pleomorphic adenoma. So it's a monomorphic adenoma. And in the lip, the most common monomorphic adenoma is a canalicular adenoma. And this has some canal-like growth, but it's more solid in areas, which moves it into a basal cell adenoma. But as long as you don't call it malignant, the treatment would be the same. Okay, next is 7-year-old with a tongue mass. Okay, what do you think's going on here? Anybody?
Squamous pearls.
Huh?
Squamous pearls, there is a lot of squamous epithelial proliferation.
So this is cancer?
No. And also we have this other cells in the stroma.
What other cells?
Like we have granular eosinophilic cytoplasm. Yeah.
So we talked about this before. So what do you want to, how do you get a diagnosis? What stain are you going to get?
PAS.
PAS. Is that going to make the diagnosis? I mean, you could do a PAS, but it's not going to tell you that it's not definitively diagnostic. S100, diffusely positive. Diagnosis? Granular cell tumor, which is a modified Schwann cell-derived neoplasm that can induce a florid pseudoepitheliomatous hyperplasia. I gave you a 7-year-old. It's highly unlikely for a 7-year-old ever to have squamous cancer. But if you look at this epithelium, if I told you it's just a 77-year-old, you might think you're dealing with squamous cancer. So when can you get a squamous carcinoma, if ever, in a granular cell tumor? How do you make that diagnosis? I mean, there are nests in here that if you take it out of context and no granular cell would look like invasive squamous cancer. So can you ever make that diagnosis in the face of a granular cell tumor?
Yeah.
How?
Two situations.
Huh? Two situations.
One,
One.
when the proliferative epithelial island is beyond the granular cell tumor,
One.
and when it is metastatic.
Okay, there you go. Okay, next case. This is 18-year-old with a cyst of tooth number 17. Other than Rifat, somebody just talk. Neoplastic, non-neoplastic. There's a little bit of epithelium on the right. It's got an eosinophilic look to it. There's this fibrous stroma and myxoid stroma. There's some odontogenic epithelium or epithelial nests in here somewhere. Right there. Clinician saying this is a mass. Anybody have an idea?
There's a lot of calcifications.
Okay, what does that mean?
That means it's a calcifying.
Okay, what does that mean? If anything, to your diagnosis, which is what we're trying to get to.
Odont, like odont, something.
Yeah, so what would you want to call it?
Calcifying, pathogenic cyst.
Calcifying odontogenic cyst. Well, a lot of things can calcify. This is not really, you have a little bit of epithelium, but it's not the epithelium we'd expect in an odontogenic, well, I guess you can have that. But the age, the history, and the morphology, particularly the myxoid stroma and odontogenic rests, this is a hyperplastic dental follicle, which is part of the tooth, which can be separated from the tooth and appear to be a odontogenic lesion, like a odontogenic myxoma. And it really comes back to the clinical correlation. Because this will be, you may mistake it for an odontogenic myxoma or a true cyst, which might engender some pretty aggressive therapy. But this is just normal component that maybe becomes hyperplastic. We look for reduced enamel epithelium. That was a little bit of what I showed you at the beginning. Odontogenic rests and mixed fibrous and myxoid stroma. Okay, I don't know if anybody has to catch a bus or not, but we have finish up.
Yeah.
Okay. So it's 33-year-old floor mouth mass. Okay. Neoplastic, non-neoplastic. Surface epithelial neoplasm or submucosal? Epithelial, non-epithelial. Okay, so therefore it's of what origin? If it's not surface and it's submucosal and it's epithelial, it has to be arising from?
No, epithelial.
From what?
Salivary gland.
Salivary glands, not a cell type, a structure. So therefore, you throw everything out that surface in your differential and focus on minor salivary gland tumors. So what do we do from here? Any particular growth patterns? Say what?
Some areas is Cribriform.
Some areas are cribriform, some areas are solid, some areas are glandular, some areas are trabecular. Nuclei are enlarged and irregular in the appearance. So what do you think?
An adenocarcinoma from the salivary gland.
What kind?
Adenocarcinoma.
How do you know it's malignant?
There was increased mitosis. The pattern is
In pleomorphic adenomas, can you have mitoses?
It's invasive.
Are you sure it's invasive? What is it? How do you define invasion here, where it's really fragmented? And all minor salivary gland tumors have no capsule. So this is a problem in the case here, unless we see it clearly grown into muscle. This is where S100 protein is helpful. Not to define the cells, but to define whether you have perineural invasion. So even if there's no perineural invasion, can you exclude malignancy? You can't. So this morphology really speaks to a particular tumor type that used to be subsumed under polymorphous low grade. This is cribriform adenocarcinoma of minor salivary glands. Not unique to the oral cavity, but fairly common, and it supposedly has nuclei that simulate papillary carcinoma of the thyroid. This is the correct growth pattern. I was looking for glomerular bodies where there's retraction of the epithelial proliferation from the surrounding epithelium, creating a glomerulus-like appearance. Okay, next is leukoplakic lesion, lateral border of tongue. Anybody? 33-year-old. HIV positive. This is oral hairy leukoplakia. EBV associated. I don't have the stains. Usually has this kind of layered, tiered look with lighter staining areas and what are called Cowdrey bodies. This might not be the best example, but those are intranuclear and ground glass. Actually, some of these have that appearance. Typically, HIV associated lateral border of tongue. Okay, the last two, 18-year-old with a large buccal mass.
Vascular lesion.
Yeah, it's a hemangioma. It's not particularly lobular, but you can put it in the lobular capillary hemangioma. But don't mistake this for an angiofibroma. It doesn't have a single cell type. It's like granulation tissue, and I think there are mitoses in here.
Yeah, there.
Yeah, so even with mitotic activity, it doesn't make it malignant. Okay, and the last one is an 18-year-old with a cyst. And this is a lesion that, we all need to identify because it has very specific biology. Anybody have a diagnosis?
Odontogenic keratosis.
Yeah, this is an odontogenic keratocyst. So the features are this wavy surface epithelium, a flat epithelium with the absence of rete, nuclear palisading along the basal membrane, and not in this particular field, but often there's retraction of the epithelium from the subjacent stroma, like here. And there's a lot of argument whether these are neoplastic or not. Some people use keratocystic odontogenic tumor. I still use OKC or odontogenic keratocyst, but these are aggressive. They need to be completely excised. Okay, we're done. Thank you.
Thank you so much.